Dr. Towen, did you want to begin?
Sure. Let's start with the first slide. Next. Next. Well, let's focus on New Mexico. As mentioned, we're going to be talking about our experience in the early psychosis clinic at the University of New Mexico. I always like to take the opportunity to share with, in this case, you a little bit more of the history of New Mexico. As you can see, New Mexico is surrounded by, on the east, we have Texas and Arizona on the west, and on the north, Colorado, and south of us is Mexico. Key point here is that we have a unique population. Next. Let me tell you a little bit about the history of New Mexico. So actually, New Mexico was, quote, discovered, unquote, quite a few years before the Pilgrims landed in Plymouth. It was the Spanish explorer Coronado who first came to New Mexico in the mid-1500s, trying to find the 7 golden cities. They were not found. But that was the first contact that Europeans had with the Native American population. Next. As it is, and New Mexico at some point was part of Nueva España, and it was conquered by who's known as the last conquistador, Oñate, who was born in Zacatecas, Mexico. And he was the first governor, and this is again in the late 1600s, or late 16th century rather, late 1500s. At the end, he was expelled as he was seen as a cruel governor. Next. So a key point about New Mexico is that we are a majority state. So the majority of our population is from an ethnic minority group. As mentioned, it was colonized by Spain. It is actually, from the point of view of size, we're the 5th largest, but the density is actually quite small. And we've been a state for a little bit more than a century. It was not until 1912 we became the 47th state. The population is relatively small. There's only 2 million people in the state of New Mexico. And a key point here is that Spanish is widely spoken. And if you look at the ethnic composition of the state, approximately 56% of the population of New Mexico is Hispanic. It is the largest in terms of proportion of any other state. There's, of course, more Hispanics in California or Texas or even Florida, but from the point of view of percent, we are the largest. Another thing that is unique about New Mexico is the large proportion of Native Americans. 10% of our population is Native American, compared to less than 1% in the rest of the country. The only other state that has the largest Native population is Alaska. So the point here is that because of our population, we have a lot of experience with Hispanic patients, and we can do studies because we have enough patients, and hopefully our presentation will help those of you treating Hispanic patients across the nation in what could be unique approaches to this population. Next. A key point is that I've mentioned before, New Mexico was actually colonized through Mexico in what's called the El Camino Real de Tierra Adentro. Next. So it makes it a very unique state. Again, we have a large proportion, 10% again compared to the rest of the nation, of Native Americans, majority Hispanic, 56%, and then of course is the major white Anglo population. It is a very unique state. We have a number of challenges. Sometimes, actually most of the time, we're bottom 3 in issues such as poverty, suicide in adolescents. Although I'm very proud to say that at this time we're top 3 in actually vaccinations. It is us, West Virginia, and Alaska who are top of the country. So I hope that with this few words you got to know a little bit more about New Mexico. So we want to share with the experience that we had with the Hispanic population. Back to you, Dawn.
Hi, everyone, and welcome. Today, we have a couple different objectives that we're going to go over. So the first is to just provide an overview of early psychosis and the literature that's specific to Latinx youth. Secondly, we're going to discuss clinician growth and awareness and ability to assess and explore cultural ethnic identity, engage clients and families, and build rapport. And then lastly, review the current evidence-based psychosocial pharmacological interventions for first episode psychosis and the applicability to this unique population. Next slide, please. So just a quick agenda. I'll start by introducing first episode psychosis, and then I'll pass over to Dawn, who's going to talk about the initial engagement, assessment, and family involvement, as well as psychosocial interventions. And then we'll finish with Dr. Toan going over pharmacological treatment. Next. So what is psychosis? I'm aware that probably many of you who are joining us today are already familiar with this, but in the case that you're not, just a quick overview or refresher that we're talking about a change in how an individual experiences the world through perceptions, beliefs, thoughts, and behaviors. That psychosis has positive, negative, and cognitive symptoms, and we view psychosis as existing on a spectrum. So there is, while there's 3% who may have a psychotic disorder, 1% with schizophrenia, there is psychotic experiences in the normal population as well, estimates of up to 20%. And that the major diagnoses would be schizophrenia spectrum disorders, as well as affective psychosis like bipolar disorder or major depressive disorder with psychotic features. Next slide. So first episode psychosis, we're talking about the first occurrence of symptoms that meet threshold for the diagnosis of a psychotic disorder. So meeting threshold means that the symptoms exist in the duration, frequency, and severity necessary for that diagnosis. Usually they're not better explained by substance use or medical condition, and onset is most often in late adolescence and early adulthood. And we usually see decreases in functioning and negative symptoms prior to the presence of positive symptoms. Diagnostic uncertainty is normal in first episode psychosis. It takes time to kind of see how symptoms develop and to be patient in making that decision. Next slide. So early intervention for first episode psychosis came about first in Australia, but researchers internationally found that interventions are more likely to be successful within the first 5 years of onset. So they call this the critical period. And specifically that the longer the duration of untreated psychosis or DUP, the more challenging it is for a person to respond favorably to treatment. So researchers started to look at what would happen if you could reduce the duration of untreated psychosis, and found that by reducing duration of untreated psychosis, you can increase functioning, increase quality of life, improve clinical outcomes, and reduce costs of hospitalizations or ER visits. Next slide. So what is coordinated specialty care, CSC? CSC is what we call early intervention in psychosis in the US. There's a bunch of different models in the US that provide CSC, but generally they have principles and concepts that are shared. So the first is to reduce DUP by increasing psychosis literacy through outreach, as well as rapid referral and assessment process. And then secondly, to provide outpatient services from a multidisciplinary team with small caseloads based in the community, focuses on the individual, and promotes philosophies of recovery, resiliency, and shared decision-making. Next slide, please. So what do we know about first episode psychosis in Latinx youth? What is the current research? There has been a recent publication that was a secondary analysis of the RAISE trial, and the RAISE trial was looking at standard care versus coordinated specialty care. And in this secondary analysis, they found that race and ethnicity was not associated with differences in psychiatric symptoms, that Hispanic participants' families were less likely to receive family psychoeducation, and that Hispanic participants were more likely to receive medication management. Again, though this was a national study and the percentage of Hispanics included in the secondary analysis was 19%. Next slide. So other studies, there have been a few, showing low psychosis literacy amongst youth and families, reduced outpatient service use, possibly more frequent encounters with law enforcement and involuntary hospitalizations. And then international research in general has shown that there is a higher risk of psychosis among minorities and migrant groups, potentially due to socio-environmental factors. But beyond that, there hasn't been a lot of research into this unique population. Next slide. So as Dr. Tohen mentioned, here in New Mexico, we have such a high percentage of Latinx, Hispanic youth, and specifically in our first episode coordinated specialty care program here at the University of New Mexico, the early program. So we have just started to take a look at this population, specifically in terms of pathways to care. And so we have recently conducted a retrospective chart review over a 2-year period, looking at the characteristics of Hispanics who were referred to our program and the factors that were associated with them enrolling in services if they were eligible. Key findings from this study were mainly that Hispanic individuals who were referred to early were more likely to be referred by mental health providers rather than other sources in the community, such as families, schools, etc. And our question is, does this mean that perhaps we need to do more targeted outreach, or would targeted outreach improve this? And then secondly, and interestingly, that although referrals came from areas with higher rates of individuals who spoke Spanish, eligible Hispanic referrals were more likely to enroll if they lived in areas with lower rates of Spanish spoken in the home. So a couple questions from that, it would be the influence of ethnic density and also the effect of primary language. Next slide. So we're here today to kind of bring to you and hopefully clinicians in general, not just those who are mental health practitioners and not just those who are already working within coordinated specialty care teams, because CSC services aren't always available. And clinicians across various settings might encounter individuals experiencing a first episode psychosis. So I'm going to pass it off to Dawn, and we just wanted to let you know that while we may suggest or recommend specific approaches for working with Latinx youth who are experiencing first episode psychosis, that it's essential that clinicians always be flexible and open to diversity within an ethnic identity. All interactions should be based on the individual, and the client is the only person who is the expert. And with that, I will pass it off to Dawn.
Thanks, Bess. Okay, so we're going to go over a lot of areas today that Bess mentioned. We'll have some discussion about case studies that might illustrate this a little bit better, keeping in mind that most people are not working in a CSC model. So, but what can we learn from this? So if we're looking at initial engagement, assessment, and family involvement, it's really important to think about who's coming to your office. the goals of building rapport with the young adult and their family. Who is involved? If the family is really involved, being able to defer to them as the experts and goal setting and what they would like to see. Pathways to care is a really important area. So as Bess mentioned, if Hispanic youth are being referred more likely by mental health professionals or inpatient, outpatient, as opposed to family members, or maybe they were just hospitalized against their will, that's a really important factor to know as a clinician with regard to being able to build rapport with someone. The main thing we really like to do as well with young adults is to empower them and who they see as their support or their identified family to the process. So it's driven by the client and the family. Specific symptoms are something that we want to keep in mind as well. So if someone comes in with some symptoms that manifest as being very distrustful of professionals or the medical system, the mental health system, there are times when folks will come in who have certain delusional thought processes that may play out with their being suspicious of their family, and yet it's a family, a more traditional family where typically the family would be involved. Those are things that you want to try to maneuver with psychoeducation and other things, but it gives you some indication of where you might go from there with regard to what someone is coming in with. So being aware of what someone is presenting with symptom-wise. As far as discussing services, this first one is really important. I've seen this over the years. I think as clinicians or folks in the field, we think we're not using jargon, but more often than not, we are. And so I think it's really important to not use terms that are psychobabble or psychological jargon, while also informing the family and using some psychoed. It's really important to utilize the client's verbiage for what's going on. So you wouldn't just start calling something psychosis. You're going to listen to the experience that someone is having, and you're going to try and use their language. Sometimes with psychoed around things that can really help and give context to what someone is experiencing. But you want to speak in a way that people understand what you're saying, and have it be understandable, of course. So. What to expect. This is an important process with coming into the mental health system. Sometimes folks will come in and this will be their first experience. It might be an acute onset of symptoms, and they're not quite sure what to expect. So transparency is really helpful in this area. And just being able to explain what this might look like, things like releases of information and confidentiality, especially if you're having someone come in and it's a very family-oriented, they want family-oriented treatment, and being able to go over these areas with HIPAA and privacy, releases of information, and just being able to talk through that so that you can really get the client's preference and involve who they want to involve. We have family here in quotes because we really identify that as who the client identifies as their support or their family. Also want to consider ethnic and cultural influences when someone is coming into your office. So I do think that this will be better illustrated later on in a case study that we go through a little bit more pragmatically. So one of the things we want to stress, like Beth said, not being an expert. It's the family who comes in, it's the client who comes in, they are the expert of their life experience. So there are ways to kind of maneuver this a bit, and I find that as a clinician, being able to create the space to discuss it and making sure that you're not coming across as an expert, because I'm not. The person coming in is the expert of their life. But there may be some information, psychoed, and the experiences and tools that we have that may be helpful to them. So this first bullet point is an area that I hear questions about a lot, and we'll demonstrate this a little bit later. So what might be the difference between a cultural expression of something or how someone sees psychosis versus maladaptive symptomology? Where do you intervene, where do you assist the family? So we're going to illustrate this with case study. You want to really get at how the family and the client view what is occurring, because you're not going to assume that an experience that they have is necessarily, you don't want to pathologize someone's experience. So you're going to look to the family with defining the parameters of what is a cultural experience and what outlies that experience, what becomes problematic or distressing for the family. So we have a definition down here for cultural proficiency, the knowledge, skills, and attitudes that enable people to work well, respond effectively to, and be supportive of people across cultural settings. The important thing is that cultural proficiency and cultural competence is not something that you ever can achieve. I think that's an important point. So it's sort of a way to walk through the world and continue to try to learn and be aware of your own experience and how that might also be influencing your work. Okay, so the setting and the environment, this is an important one. I've heard this even over the last couple of weeks a few times with regard to someone coming into services, and you have to consider the factors of someone's life experience. So the access, technology, especially now with COVID, do these folks have access to computers, to being able to do telehealth? Transportation, can they get where they need to get? A lot of times I've seen where folks might identify a lack of motivation for a family when in actuality a parent doesn't have the option to take off from work to go to an appointment because they'd lose their job. So I think it's really important to consider who's coming into the office, what are the barriers, what are they facing, and so and not forming conclusions around that. It's also with awareness as far as the experience that people have had with the medical or the mental health system. So when your family client comes in, getting an understanding of what their experience has been like is going to be really important for rapport and how you might proceed. The history and bias with clinical assessment. Something I like to keep in mind is that a lot of the assessments and tools that have been developed were developed by white people and were tested originally on white people. I think that there's a balance when you're functioning in a medical system and having to use ICD-10 codes and do certain assessments that your agency or your facility may ask for, and being able to get what you need in a sensitive way and being fluid with how you might go through these assessments. Checking biases and assumptions. So identity is not static. This, I think, also goes back to one of Bess's points as well with regard to language and other things. Sometimes we'll see folks come in where what the young person might identify as their goal looks really different than what their family as a whole might have hoped for them. That might be due to some assimilation or individuation, developmental tasks, other things like that. So, and diversity within the Latinx intersectionality. So being from the East Coast, that looked quite a bit different. I was living in an area where there was a very large Puerto Rican population as opposed to where I'm living now in Albuquerque and what that looks like. So being aware of some of the things that regional wise that people might be facing. Okay, so addressing language barriers. Client is never asked to act as an interpreter ever. This is very detrimental in so many different ways. But there's nuances here that are difficult. So interpreter services, making sure that you are prepared and what you can access interpreter service wise, making sure that you are speaking directly to the family and the client. The interpreter is there to verbatim say what you are saying. So there's a couple of different areas that we think about here with regard to considerations. So again, going back to not using jargon, if you have an interpreter and you're using medical jargon related to psychosis and other things, there may be a gap there with regard to the person's fluency and having the clinical language for things. You always want to explain things that are understandable. as well as looking at, as Bess mentioned, there are cognitive deficits and other things that happen with psychosis. So is there some things happening with regard to the person that you've identified as the client and their ability to discuss what's going on, or being disorganized, and using an interpreter there. So we're going to move into psychosocial interventions to try and illustrate some ways to join with folks, some ways to goal set and look at how to increase someone's function and decrease their distress. So as we talked about, the CSC model is multidisciplinary. We're aware that there are folks probably watching this from lots of different places that don't work on a team approach. So we would recommend that there is a open communication, releases signed in order to work with different supporters of the identified person. Recovery oriented, we'll go into what is recovery in a little bit. And so we're focused strengths-based and working toward recovery. It's a strengths-based model, building on someone's tools, skills, and supports. It's individualized, so there is no sort of scripted, this is what it's going to look like. Each family that comes in, each person that comes in, there are modalities and there are folks that do specific things on the team, but you're really going to individualize it towards that specific person. And I like to think about, as a clinician, my role being to assist someone in increasing their function and increasing their fulfillment. Those are the two areas that I'm consistently thinking about. So I have this question down here, whose goal is this? And we're looking at that because I think there are times that as clinicians, if we're looking at recovery or wellness or success, clinician really needs to be aware of how they're defining that versus how the person's come in, how they've defined it and how their family has defined it, whoever they identify as their family. So the clinician is open to learning and is not the expert on that person's experience, but again, has some tools and other things that with psychoeducation, you're sort of meeting in the middle with teaching each other and learning from each other. Developing common language. Again, I think it's important to utilize the clients, the words that they use for their experience, and then providing some psychoeducation around how common it is to have these symptoms. Okay, so here's a case example that I think may help with some of the areas that we've looked at and make it more pragmatic. So Sophia is a 19-year-old Hispanic female, comes to the clinic, the urging of her aunt and uncle with whom she lives. Her aunt explains that Sophia has always been a sensitive child and that she communicates with her abuela, who passed away when Sophia's mother was pregnant with her. Gathering information, the clinician learns that the family sees Sophia as having a gift. Sophia has been hearing her grandmother's voice since she was a toddler. This has always been comforting to Sophia, as she has always felt like her grandmother has been looking after her. Recently, Sophia's family has noticed changes that are concerning to them. She's easily agitated. She reports hearing other voices. In addition, she's stopped socializing and her grades in school have dropped. So how would we help Sophia's family differentiate what they see as a gift versus what is outside the realm of this gift? So one of the things that you would want to do is really gather the experience of the family and the collateral information on how Sophia's experience and function has changed. So one of the things that Bess went over in the beginning is when we're looking at symptoms, we're looking at the start of positive symptoms with regard to maybe hearing, seeing, experiencing things that other people do not. So when you gather this information, though, you would not include Sophia hearing her grandmother's voice as a symptom. So what you're looking at with regard to working with this family is looking to them to identify when this experience has changed. So the onset of symptoms would be when the family starts to become concerned. She's hearing other voices. She's not doing well in school. She's experiencing things outside the realm of that. So this was a situation where, when discussed further, the family started to identify that Sophia started to play music really loud in order to try and prevent the neighbors from hearing her thoughts. She also was really distressed by if any of the other kids in the family watched television, because she thought that there were some messages coming through the television for her specifically. And at one point had even felt as though the neighbor was using the uncle's body to get to her, so as an imposter, so that the neighbor was in the uncle's body, which is called Capgras syndrome, which is where someone misidentifies people that they should know, places and other things like that, and thought that her uncle was actually an imposter. So that gives a little more information about where the situation may have changed. So that's where things became problematic. So that's what we're looking for with regard to when does the person become distressed? When does something go from a cultural experience to something that's maladaptive? Well, if somebody's come to your office for care, you can probably assume that there's something that's distressing or not going well, that they're help seeking, but you're looking at when the change occurred. So if I'm not really quite sure, and again, I'm not an expert, so I would wind up talking with a family, and if it's a cultural experience that they're sharing, I might engage with them around how might folks who experience or are part of the culture see what's happening now versus what would be described as cultural, just so that they can assist you with understanding. So defining recovery, this is something that's sort of always been a hot topic. I think some people define recovery as being free from a condition, that it's no longer there, versus the condition or symptoms no longer prohibits one's life. So I think it would be very dismal to present to anyone, whether it be mental health, medical health, or anything else, that you have to be free from a symptom or free from the condition to be in recovery. So we go with a working recovery model where someone is able to maintain self-care and engagement, increase their function so that they're doing the things they'd like to see happening. They're maybe in school if that's what they want to see, or their relationships are doing well. They're able to work, they're able to contribute in some way. When does someone feel their best? Working recovery is being able to use those tools in order to function where someone feels like they're doing okay. So what's off limits? These are some areas that we might get into with the RAP plan and other areas on things that are just not helpful for us versus non-negotiables, and what are things that we make sure we have to do in order to continue to feel well. Some folks with non-negotiables and other things have a ritual in the morning and in the evening. Sometimes I'll work with folks around that. That might cap a day. And for someone who might be a bit disoriented, that might help orient someone to time a little bit more. We'll go over a couple of areas. CBT for psychosis. This is something that I think folks are familiar with CBT overall. We're not going to go too in depth with this. There's tons of trainings here, specifically for psychosis or clinical high risk for psychosis. And what CBT for psychosis really does is we're looking at distress and disturbance associated with the symptoms. Secondary morbidity, which there is a lot of with depression and anxiety, residual psychotic symptoms. If you have not taken a training with Dr. Kate Hardy, I would highly recommend it. I think she is absolutely wonderful, and I love this quote by her. We don't question the reality of the symptom, we strive to reduce its damage. And so I think this is really important when working with folks who might have a different reality or have symptoms of psychosis. You're not going up against and telling a person that what they're experiencing isn't real. You're looking at what's helpful and not helpful. I think a lot of people have the experience, particularly families, if they're not quite sure how to handle what's going on, and they're saying that what the person is experiencing is not accurate, and they're doing it in order to try and assist and reassure the person. But a lot of times what we'll see is that the person will become more agitated and things get really difficult. So how do we do this? This is another case example in working with someone that has some symptoms. So Marcos, 17-year-old male who has a 6-year-old half-sister, Becca. Becca's refused to spend time at the house and has informed her mother that it's because she's frightened by Marcos when he starts yelling at people who aren't there. The therapist ascertains that Marcos likes listening to some of the voices, but that others become abusive. So this is a common experience that you might see where someone is experiencing things, but only some of it is problematic to them. And so, you really want to engage the person there and look at what are the goals for what they want to see happen. So in this case, how would we assist Marcos with this? One of the things that I do with people sometimes, and in this case, this was a situation where really exploring what was going on. So Becca, who would come over to the house on occasion, who split homes with her other parent, would think that Marcos was yelling at ghosts. And so this would terrify her as a 6-year-old, and she didn't really want to be around him. And that was very distressing to him. He was very, very distressed by his sister not wanting to be around him. He loved spending time with her. One of the things that we looked at with regard to this was what's happening with Marcos's symptoms and the negative impact. So sometimes joining with the person within this, that was a discussion around sometimes Marcos, even in session, would start tend to the voices and be talking to the voices and then sort of come back into session. And so identifying that it must be hard for him to tend to and to be present in the conversation if he's doing that, which he endorsed that it was really difficult, as you could imagine it would be. And so one of the things that we are able to focus on is looking at lessening the impact. So if he's with his sister, and one of the examples I would use is if they're playing a board game and one of Marcos's friends called on the phone and they had planned that they were going to talk a little bit later on, how would Marcos handle that? And his answer was he would say he's busy right now and that he would call back later when they had planned to speak. And so taking that, is that possible with the voices? There's a lot of times when we can assist somebody with scheduling things, compartmentalizing things, and increasing their function. So if he's able to sort of think about, I'm going to tend to these voices later on, I am busy with my sister, you'd be surprised that sometimes, the brain will allow that to happen, and it gives the person a sense of more control. So we went through some tools with regard to how he might be a little bit more present and put time aside to tend to things, so he could really focus on what was happening in front of him or spending time with whether the therapist, the sister, or whoever. IRT, individual resiliency training, is a talk-based therapy that really looks at identifying strengths and self-management tools. So individual resiliency training, we're not going to go through too much of this either, but there's a lot of plans that go into this. So you're really developing structured plans, incremental steps in those plans, relapse plans, lots of different things that walks a person through their skills, their supports, their tools, and how to go about things. And then also, relapse planning and other things like that. So I'll get into a little bit more of this later. Functional focused approaches is I think an area that is most beneficial here. So what we're looking at is how do we increase someone's function? How do we decrease their distress? Those are typically the two areas that as a clinician I focus on. And so the person might come to you pretty symptomatic, and they might be also treated by the MD. And your role is also to look at how to decrease distress and how to manage what's going on and increase function. So we also have folks through our program who don't take medication, opt to not take medication. And so some of these things that we're doing is to help them look at symptoms and how to manage them. So occupational therapy, CSC model has OT as a part of it. I think sometimes people think OT when someone has had an accident or something and they're trying to increase function after an injury. OT actually started in mental health. So what we're looking at is how to increase someone's function just generally. We know that executive function comes undone a little bit. We know that folks have difficulty with concentration, with organization, and other things. So strategizing tools in order to compensate for that and to find things that might work for the person can be really, really effective. I like to use executive functioning tools and other things. We're in the age of technology, so you might as well use it. Nobody looks at you funny if you've got an alarm that goes off on your phone, or you're able to schedule things, reminders and other things. I love color coding, and I go over that with people. That can be really helpful. If someone, let's say, I'm sure folks have heard of this example. Someone forgets their medication frequently, but you know that they do something on the regular. So if someone definitely brushes their teeth every morning, putting the meds next to the toothbrush is an easy way to sort of help remind. We talked a little bit about non-negotiables and alarms. Scheduling symptoms is what I talked about before. That's very effective for comorbid anxiety and other things as well. Sometimes we'll see anxiety goes up significantly. And similar to if you've got a list on the refrigerator for when you're going to go to the grocery store and you write something down as you realize that that's something that you need, you can do the same thing with worrisome thoughts and other things where you're bulleting, and then at the end of the day or an identified time, the person can sit down and worry for an allotted amount of time about those things. And again, it can really assist with increasing function and attention and being present in what's happening at the time, writing down a couple of things so that later on they spend maybe half hour, 45 minutes, and all they're doing is worrying about through that list. The WRAP plan, Wellness Recovery Action Plan, is a preparation for what might happen. It does go over when do I feel well, what do I need to feel well, what are some things I do on the daily, what are some things that are important to me, what are some things I definitely can't do, what's okay for me, what's not okay for me. You can get this on the internet, and a lot of worksheets that work somebody through being able to develop some increase intuition about self-care and developing specific plans. I like to talk about plants, pets, and people because it's unbelievable the amount of times you may see someone who is not willing to seek treatment or go into the hospital or do something that they feel like they need for themselves because of their cat or because of they've got a lot of plants and a garden and it needs to be tended to. These are things that are really important to people, and so to have the time to have a plan with regard to if something happens, this is the person who comes and feeds my dogs, this is the person who does this, can really help somebody feel a little more open to doing what they need to do to take care of themselves because the things that they prioritize are taken care of. And I like to use a lot of metaphor with folks. So I compare this stuff to a car or a road trip. So when I go on a road trip, I've got a spare tire, I know how to change a tire, I've got water, I've got blankets. I don't want to assume that I'm going to break down in the middle of nowhere, but I'm prepared for it. And for me, that brings down anticipatory anxiety. So you're doing the same thing with regard to WRAP plans and other things. You're preparing for what might occur and making sure you have the skills and tools to deal with it. And you're hoping it doesn't occur. But if it does, you know what to do. A couple of things that are really important but under-discussed. I think one of the most under-discussed areas is sex health and wellness. And I think this is throughout all of mental health or the SMI population. It's an area that is really not looked at, and it's an area I talk about frequently, both suicidal ideation, suicidal behavior, as well as sexual health and wellness. It's important to have these topics discussed often and that there's a comfort level by the clinician so that you've created the space for someone to talk through these things. Boundaries and intimacy, medication and sex. Medication that is prescribed will be gone over later by Dr. Towen, but there are some side effects that can happen, symptoms and sex. I've talked with clients before where the intensity of sexual encounters can make their symptoms go way up. So, and that's not something I would have talked with folks about or known about unless we had been talking about sex just in general and sex health and wellness. And so how to maneuver those areas, these are really important areas for people. So it's important to be able to talk about this, intimacy, dating, disclosures, all things like that. Suicidality, there's some great tools and screens and other things that should be done frequently. The Columbia screen is one of them that I think is really good. There's a whole bunch of tools online as well. But it's really important when we think about early intervention with psychosis that we normalize and we discuss suicidal ideation. There's such a high risk for this population with regard to 1 year post being hospitalized or diagnosed, it's a very, very high risk. So you want to be able to just not ask questions about, have you thought about death? Have you thought about hurting yourself or dying by suicide? But to really normalize that people do have this thought process, being able to have the space where somebody knows they can come in and talk through things with you. I think that it is an area where people fear that if they talk about it whatsoever, they're going to be sent to the hospital against their will. And so normalizing the difficult stages in early recovery, normalizing that this is a common experience for people, and thinking about maybe it would be easier to not be around, or wishing that I went to sleep and didn't wake up, those kinds of things. Being able to skillfully talk through and assess suicidal ideation, suicidal behavior, protective factors, and other areas. So that's an area that I would recommend that people spend time on and increase comfort level, because the comfort level of the clinician is going to increase the comfort level of the person you're talking with. Okay, so we are going to turn this over to Dr. Towen for psychopharmacological treatment.
Yes, and there are three topics that I want to cover within pharmacological management. One is diagnosis. The other one is, what are our goals? Is it just diminution of symptoms, symptom amelioration, or is it function? And as mentioned before, functional outcome, it's key. And then let's not forget that we're talking about the Hispanic population. So I will make general comments in terms of medications, but also emphasize what is unique about Hispanics. And talking about Hispanics, let's remember that Hispanic is not a race, it's an ethnicity. So you can have Hispanics of any race or combination of them all. So it's more an ethnicity. So it's a cultural difference more than the biological. So, and I'll get to that in a moment. Let's get to diagnosis. So we've been talking about first episode psychosis. Psychosis is actually a symptom. It is a symptom that can be manifested in a number of different conditions, and we can divide them into the affective psychosis, that's when you have mood symptoms, and the non-affective psychosis. So the affective psychosis are two major ones. One is bipolar disorder, and the other one is psychotic depression. The prevalence of bipolar disorder is actually larger than schizophrenia. So there is a large percentage of individuals who have psychotic symptoms and their diagnosis is bipolar. And then you have the non-affective psychosis. It's what we would normally, the majority of them would have schizophrenia, but then there's other diagnoses. So again, psychosis is a symptom. Now, medications are approved by the FDA depending on diagnosis. So you can have medications, for instance, antipsychotics, that they're approved to treat schizophrenia because schizophrenia has psychotic symptoms, but also bipolar disorder because psychotic symptoms is a component of bipolar disorder. So there's so-called first generation antipsychotic and second generation antipsychotics. And I'll talk a little bit about the differences, but getting back to ethnicity. From the biological perspective, there has, and actually efficacy, studies have not shown that certain medications, you have a better response with Hispanics than in non-Hispanics of any race. So in terms of efficacy, we don't really see any differences. In terms of side effects, we do, and I'll talk about it. And actually, the vast majority of you, 78% of you, indicated that you expected to see more metabolic changes in Hispanics than in non-Hispanics. And as I mentioned, it has nothing to do with the race. It's really, in this case, ethnicity. So it is actually related to culture and what people eat. Let me talk about efficacy. So we mentioned that there's two types of antipsychotics. And also, when you have a patient with psychosis, you can see the patient with psychosis in the emergency room. You can see the patient in an inpatient unit, or as we do in the outpatient setting. The advantages of the first and the second generation is not really that clear. Let me just give you an example. In terms of onset of action, how fast do they work? Actually, the first generation antipsychotics, like Haldol, works faster. So many times when you're in the emergency room and you want the symptoms to improve as soon as possible, you would use the first generation antipsychotics. Now, the second generation antipsychotics are better tolerated in a number of symptoms, but unfortunately, it has other symptoms. We don't have the tardive dyskinesia with the second generation that you have with the first generation. With the second generation, well, they're better tolerated. You do have a side effect that is actually quite concerning, which is obesity and the metabolic syndrome. And this is the situation where you see it different in Hispanic and non-Hispanic patients. In general, and most likely due to the diet, Hispanic patients with first episode psychosis tend to gain more weight than non-Hispanic whites. So again, this is something that you need to pay a lot of attention, that the risk in general, on average, the risk of metabolic syndrome is obesity, hypertension, increase in lipids. The risk is higher in Hispanic than in non-Hispanic patients. So when the prescriber makes a decision of which medication to prescribe, when you have a Hispanic patient, you need to take that into account. And I do understand that many of you do not prescribe medication. Some of you do, nurse practitioners, primary care physicians, and psychiatrists, but many of you do not. It is important to know the not only the benefits, but also the side effects of the medication. Like for instance, in the early clinic, we meet as a group, and when we discuss different patients, and there might be that, Dawn mentioned sexual adverse events and medications. It might be that the patient had not mentioned to me particular adverse effect, sexual adverse effects. For instance, with males, you have diminished libido with a certain medication. So it might be that that the patient revealed that to the psychotherapist, not to me. So that is an important thing. When it gets to dose, the lower the better, because there's a close relationship between dose and adverse events. And with first episode patients, this is very important, the tolerance of the medication. It's like a first impression. When you have patients with chronic conditions, they've taken different medications, but first episode psychosis, this is the first time that they receive medication. So if the medication produces a lot of side effects, that experience is not only have the patient have concerns about that particular medication, but that might extend. So patients will not want to keep taking medication, they have side effects. The other key thing about first episode psychosis is that the vast majority of patients, after they've been treated, they have no symptoms, okay? They improve. So the recovery is actually more ad integrum than with the chronic patients. So many of these patients are doing well, and then they're having side effects. And as I've mentioned, unfortunately, most medication have side effects. So you really want to minimize the side effects, because that is going to have the patient not only initially, but through their condition, be against the use of medications. Duration, how long should an antipsychotic medication be prescribed to a patient? There is no clear answer. Unfortunately, the vast majority of patients with psychosis, affective or not affective, it is a lifelong condition. There is a small amount of patients, but unfortunately it's less than 10% that have a single episode only. So we need to be prepared. We need to talk to the patients about a very common question that patients ask me is, Doc, how long will I be taking the medication? My honest answer in most cases is not until we find a cure. Because if we stop the medication, then the symptoms are going to increase. Monotherapy is better. Patients are more likely to take a treatment, pharmacological treatment, if it's one drug as opposed to more. Non-adherence increases as you increase the number of medications. And let's talk a little bit more about non-adherence. I'm sure you all heard about long-acting intramuscular medications. That is a medication that you inject, and sometimes you can wait actually 3 to 6 months with some of them. The vast majority is 1 month. For the most part, those long-acting intramuscular medications are used in chronic patients, but that is probably not the only population we need to focus on. And specifically with first episode psychosis, non-adherence is very high. And again, for the reason that I've mentioned, patients get better, but they have side effects. So thinking about long-acting intramuscular is actually very important. We've had many patients that come into the hospital, take their medication, leave the hospital, stop their medication. So that's why we need to start a long-acting intramuscular. Let's move to the next slide. And a theme that we've been talking about is that this is a shared decision. So in terms of the medication, what I do, I let patients know what is the risk of, well, the efficacy of medication, but also the side effects and what are the side effects we want to avoid. Now, these are young people. We see a lot of college students. So it's not only the improvement of symptoms for psychosis to disappear, but also at what expense. So functioning is key. We want that young person to go back to school. We want that young person to go back to work, or we want that young person to be able to take care of their children. So very much functioning on not only symptomatic outcomes, but also functional outcomes. And be alert of the discontinuation. Sometimes patients might tell us, well, I'm taking my medication, but that means taking it maybe once a week. And of course, that doesn't work. So that is why it's key to work as a team, that the therapist or the occupational therapist can let me know in terms of the adherence, but also in terms of the side effects. So again, just to summarize, from the point of view of Hispanics, no difference. Studies have shown no difference in terms of efficacy, but there is more side effects when it comes to metabolic syndrome and increased appetite. As mentioned, I do not think that's biological. It's more having to do with culture and also getting the family involved. That is key, because and I always tell my patients, in order for me to provide you the best possible treatment, you need to give me permission that I can talk to you, and most of them in this case, because they're young, your parent, your significant other, and that way I can see how much the medication is helping you or to what extent you're getting side effects from the medication. So, okay, team approach, not only in terms of the treaters, but also working with the family. Back to you, Dawn.
Thank you, Dr. Tobin. Let's see. Okay. So a couple of conclusions. One of the things that we want to stress is that treating Latinx youth, the model isn't really different than treating anyone else, because it is always based on the person who's coming in, what their life experience is, and being aware of that. So that said, I think that there are some things to think about as a clinician that I think are really important. So learning about a culture and thinking that it generalizes to all people who maybe identify within that culture is pretty off base and offensive. So I think it's one of those things, there's a balance between being informed and thinking about the specifics of what someone might experience as a Latinx youth, and regionally where they live. There's going to be a different experience on the Northeast coast as compared to the US-Mexico border. There are going to be different factors there. So at the same time, you don't want to not be aware of what's happening and what people might be facing. So treating everyone the same is also sort of tone deaf. So I think there's a balance between trying to educate yourself for the issues and areas that somebody may be dealing with because of their life experience, and also keeping awareness of what your views might be, things like, you know, implicit bias and what you see as success as compared to what the person coming in might see as success. So one of the things that I think about as a clinician too is just the humanity of the experience. So I think as people, regardless of culture, we want some of the same things. We want what's best for our children. We want to be happy or to avoid suffering. We want to have a purpose and contribute in some capacity, and we want to belong and be valued. So cultures that value the individual may differ from cultures that value the collective in the how that looks, but ultimately those are some things that I think we all strive for as people. So I think it's really important to think about areas that people might be experiencing, educating oneself about historical and cultural experiences, the political climate, and what that might look like for folks, and areas about accessibility and equity and equality. So there's a lot of areas to think about and to apprise oneself about, but to continue to be open with regard to continuing to learn and not presenting yourself as an expert, but being aware of what someone might be facing, presenting tools, normalizing education, psychoeducation, and also finding that common ground and an area to meet in the middle. And that is always the clinician's responsibility. It's never the client's responsibility to bridge those things. So self-awareness and continuing to learn and encountering things in a way and engaging in treatment in a way where you're making sure that the person that you're with is identified as the expert and what they want to see happen. And then how can we remove some barriers, lower distress, increase function, those kinds of things. So, and it's a privilege to be doing that. So I think presenting with gratitude to the individual and the family that they've invited you in some capacity at this point in their lives at a very difficult time can really go a long way. And that rapport can really help as well. So let's see, I want to be cognizant of time. I think we're about at 11:15, which is where we wanted to be for questions and other things. So I will hand it over to the moderators.
Thank you very much for just a wonderful, beautiful presentation. We have several questions. Some of the questions are regarding the use of translator interpreters. The first one is, could you explain more fully the pros and cons of using native speakers?
Maybe I can talk here. So I happen to be bilingual, as you can tell by my accent, and I'm also an immigrant. And in New Mexico is, as I mentioned initially, very unique. So we have Hispanics who have been in New Mexico for 400 years, who speak no Spanish. Okay, so you have those, and then you have immigrants like myself who are bilingual. But you also have Hispanics that are Spanish monolingual. And that's usually when you have young patients, usually the child, the adolescent speaks English, but not the parent. So this is why this gets a little, I wouldn't say complicated, but you need to pay attention to that. As it is in the clinic of the prescribers, there's 3 of us, 2 of us are Hispanic, and that is just it's just as it is. I think that you do not need Spanish speakers providers to be able to treat Hispanic patients. It's not that you can use the interpreters, but I would pay a lot of attention of what Don mentioned, that it's the right use of an interpreter and not to have a family member. It is helpful to be bilingual because, again, with young patients, you can talk to the parents and also to the patients. I'll let Don and Bess add to my comments.
Hi, I would also just add, as a non-native speaker, you know, you can sometimes help to build rapport or show that you have a certain level of dedication and interest and curiosity in connecting with them. But at the same time, the con would be that you don't want to assume that your language abilities are good enough to be an interpreter or to provide psychoeducation or to provide clinical care. So I think that's one of the pros and cons, or some of the pros and cons of being a non-native speaker trying to connect, and you know that might be interpreted well, but it also, if used improperly, could be detrimental.
Agreed. I would just add as well that some of what is seen when the child or the young adult is put in the position where they're interpreting is things are left out, things are presented a certain way, or it also puts a young adult in a role that they shouldn't be in. That the focus should be on us supporting and assisting them and not being in a role of them having to interpret back and forth. So the other thing that I think is important as well is that when you use an interpreter, that the interpreter's role is to verbatim say what you and what the other person is saying, and to make sure that you're communicating with the person, not the interpreter. The interpreter should be, their role is to obviously bridge that, but to make sure that you're continuing to speak directly to who you're speaking with, to the family, to the client.
Let me add another comment here. So as mentioned, sometimes we have young adults who don't speak Spanish or some Spanish, but then the parent does not speak English. So what I usually do if I'm talking with the parent, I ask my patient if he prefers, let's say the patient is bilingual, I'll ask the patient, do you prefer if I speak in English to your parent, or do you prefer Spanish? So I give that to the patient to make that decision. And then, of course, I might talk to the parent in Spanish. And then if the patient doesn't speak English, I will, of course, Spanish, I will just translate there. So, but I always ask the patient, my patient, who I have the primary obligation, what language do you want me to speak, if there's a difference in terms of the knowledge of both languages in both the patient and the parent.
Thank you. Thank you very much. We have another question regarding, I am interested in hearing an example of how a clinician might open up the topic of ethnicity with their clients.
Could you repeat how what? Can you just repeat the question, please?
Okay, so she was asking how to start to talk about ethnicity with their clients. Like if you can provide an example.
One of the things that I do is to ask the person about themselves. I mean, I think sometimes people are asking direct questions about what is your ethnicity, what's your cultural experience. You can also fill that out with, tell me some things that it's important for me to know about you, or tell me about your family, tell me what's important to you. What do you guys celebrate? What are some rituals? What are some things that are important to your family? Sometimes we'll see that someone will come in, and it's interesting because we see young adults that sometimes their culture, they don't identify it as it being really important to what they want to discuss, or it might be a little bit different with what their goals are. And if we've got family members who have come, let's say from Mexico, and the parents speak Spanish and the young adult speaks English and a little bit of Spanish, and sometimes folks do want to discuss how things are different with their goals for their life as opposed to what it might be in their family or what the expectation is. So you're creating this space for people to talk about what they would like to talk about. And sometimes I'll just identify too, naming it. So, you know, coming in, and I may say some of the tools that we're using or questions may be uncomfortable. I sometimes will talk about assessments and who created them or who they've been utilized on initially. I'll identify myself as, you know, what might it be like to have this conversation with me as a white woman who some people can identify I'm from the East Coast on occasion. So I'll just bridge the conversation and make it also a topic that's okay to discuss. And when you name it, I think sometimes people are able to then say, you know, it's like this for me, or I'm not comfortable with that, or it is the fact that you're white, or the fact that I'm, and whatever that is. I mean, I think if you make it a topic that's okay to discuss and you bridge it, it's more comfortable for people just in general.
You know, the other thing is, as everything in life, don't generalize, don't make assumptions. So we just don't know if the young person thinks of herself or himself as Hispanic. And this is not how you look, because as mentioned, Hispanic is any race, but who do they identify with? Because certainly the parents, if they're recent immigrants, they think themselves as Hispanics. But when you have first generation patients coming from a Hispanic patients, they in fact might not want to consider themselves Hispanic. So I think it's important to ask. One should never assume. And back to our topic, in our particular case, I've mentioned the side effects of metabolic syndrome. In this case, it would matter because of the diet. I think it's just, one would just be open, indicate what are the type of foods that are going to make you gain weight, and also emphasize that the medication will increase your appetite, and with certain foods you gain more weight for the other. But I think a key thing is just to don't make any assumptions of how the patient sees herself or himself.
Dr. Toin, I think we have another question. How common is it for youth to never get relief from hallucination in spite of trying various medical interventions?
Yes, that's of course an important question. Unfortunately, not every patient responds to antipsychotic medication. But again, it really depends on the diagnosis, because again, you can have psychosis in different conditions. In fact, let's talk about schizophrenia. So we have what we call positive symptoms, hallucinations, which is hearing voices or seeing things that others can't see. And you have delusions, and delusions are false beliefs. So those are positive symptoms, hallucinations and delusions. And then you have the negative symptoms. And negative symptoms is when the patient actually does not interact, has poor motivation, poverty of speech. And the positive symptoms, the hallucinations and delusions, respond better to the antipsychotic than the negative symptoms. To up to date, we do not have a medication that actually treats negative symptoms. The medications that we have treat the positive symptoms. But another point that I emphasize with my patients is that this is just improve your symptoms. If you stop them, the symptoms are going to come back. And then another key thing is that patients, it's not that deny symptoms, there's a term called anosognosia, which means that the patient is not aware that she or he has the symptoms. So the patient might say, well, no, I'm perfectly fine, so I don't need medication. And that's when the family member becomes important. Well, as the family member, well, in your opinion, is he or she back to their usual self? But getting back to the question, and I think maybe a number, I should offer a number here. I would say that 10, 15% of patients with the use of antipsychotic symptoms, the symptoms don't go away. And then there's different kinds of medications. There's a particular medication that is called clozapine, which is the most effective, but it's also the one that causes the most weight gain. So you really have to move by stages to, is it the efficacy or is it the side effects, and move along and continue. But as I said before, medications until there's a cure, and there isn't, I do like to give my patients hope, and I tell them that probably within our lifetime, or at least their lifetime, there'll be a medication that's going to be not only improving symptoms, but also the conditions. Back to you.
Thank you. This is helpful. Another question is, do you have any advice when working with clients who are Hispanic or Latinx and are resistant to therapy or mental health in general? And then she explained, I know in my family, we identify as Mexican. Mental health was a taboo topic and no one's comfortable talking about. And with some of my male family members, they consider it as a weakness. So the question is how to provide advice to Latinx clients that are resistant to start therapy or mental health.
My approach with folks is to talk through that, and I don't think it's an uncommon experience, or sometimes it's not an uncommon experience for just teenagers to be reluctant to engage in therapy or services that way. So I think that being a strengths-based model and looking at function and fulfillment, things can really be approached or worded in a way that might be helpful. So I work with some young adults who family members don't consider therapy to be something that they would naturally seek out, or consider it a weakness. And so I have at times talked about things in more metaphoric terms with folks, where they're almost seeing me as a coach as opposed to a therapist, and we're going over certain skill building and tools, as opposed to like, what is counseling versus someone coming in and saying, you know, I really want to get back into school, but I was going to school full time and then I was in the hospital and I'm not quite sure that I can handle it. And so what we look at is sort of training analogies and stuff like that. Young male adults, I have found that not that it doesn't work for females, so I use it as a sort of like a sports or being a runner. And so if I were to have an injury and I'm a marathon runner and I had surgery, I wouldn't go back to running a marathon right away. I would probably rest it, follow advice, go to PT, those kinds of things, and slowly work myself up to running long distance again. So we can really look at things, I think, in metaphor. It could be helpful for teens, helpful for people just in general, with regard to, rather than that all or nothing, and incrementally building steps with regard to training and using natural stress to build strength and tool and skill to get back into whatever the activity was. So if we're talking about athletics, it might be walking, working with a physical therapist, specific exercises, those kinds of things, you know, shorter distances, things like that, and then eventually building. So if someone wants to get back to school, it might be taking one class where they are taking a class that they enjoy at the local college, just to get on a schedule and have to get somewhere, using all that executive function with being on a schedule, all the things that it takes to organize, to be in a classroom setting, those kinds of things can incrementally build strength. So I a lot of times won't call what we're doing counseling. A lot of times the OT as well, we'll call it consultation, we'll call it function skill building, we'll call it different things. So I think being aware that someone is, that they feel that way about counseling or the mental health system, and looking at how to remove some barriers and how to support them, case management, other things like that. I think a lot of folks sometimes too, when they come in, if they don't want to look at mental health services, they really want to work on logistic, getting some stuff off their plate. So there might be outstanding bills from inpatient hospitalization. There might be they had to drop out of school and they didn't leave in good standing. So there are things that I find that people might be more apt and open to with regard to logistics and getting things done. And then with some rapport and stuff, sometimes people are more apt to engage further with different team members.
Actually, if I may add something here, the question was also related to wanting to receive mental health. Unfortunately, the stigma against mental illness doesn't respect race or ethnicity or age. The stigma against mental illness is unfortunately universal. And it's not only about the person being mentally ill, but also there's a stigma against providers. I'm not gonna see a therapist, or I'm not gonna see a shrink, and so on. But more specifically to the question, what about Hispanics? And data does show that the stigma against mental illness is higher in Hispanic cultures as opposed to Anglo cultures. So it really depends, but I would emphasize here, don't make the assumption. But in general, the stigma would be higher, but not necessarily. As mentioned, many Hispanics have been here for centuries. Some are recent immigrants. So I would say that in general, with recent immigrants, you will find more of a stigma as opposed to those who have been in this country for a number of generations. Back to you.
Don, thank you very much, Don. I don't know if you can show the last slide where the participants can complete the evaluation. And the last question is regarding tools. The first one is if you can provide more tools regarding executive functioning, and the other one was regarding psychoeducation about psychosis. To like if you have tools or kind of recommendations.
I didn't get the full question. I'm sorry. Tools for psycho ed versus?
Yes, tools about executive functioning that you recommend, and also maybe fact sheets or documents about psychoeducation regarding psychosis.
Yeah, absolutely. So there are some great websites. I think Bess had some on the earlier slides. ESA, Navigate. SAMHSA has some great stuff with regard to psychoeducation, so that you can find some nice overview for early intervention psychosis, some tips, some tools, communication strategies, other things like that. What might your loved one be experiencing? I don't know if you guys give out our information, but feel free to reach out. We have things we would be more than happy to share with whomever. As far as executive function, so utilizing an OT can be really helpful. I know people don't have access to that a lot, but there are some tools that are strategies and other things with being able to try and identify where the person is having difficulty. So it might be someone who was doing really well in school, taking a full course load, working, and then when we see them, they may have difficulty putting a thought together. They may have a lot of difficulty with regard to orienting to time, what it would take to get somewhere on time. There's a lot of processes that I think we take for granted when we're feeling well that come undone when we're not. So tools and strategies to overcompensate for those things. Some of the things we talked about with regard to color coding things, using alarms, schedules, things like that. I also think that there's a lot of information. I find this really helpful with regard to sensory processing. So a lot of times people will describe, even though they might be coming across as blunted, that they're quite overstimulated by what they're experiencing. The brain sometimes will stop triaging sound in the way that, you know, if we're having a conversation in person and you hear the buzz of lights and a car go by and that kind of thing, you're still able to hone in on my voice. And the brain stops being able to do that for a lot of people so that it feels like it's at the same level. So teaching people strategies with regard to sensory input and how they might be able to de-amplify some of that, amplify other areas. It's a big topic that I think we could probably do an entire training on working with different executive tools and strategies to help somebody with their function. So some of the occupational therapy tools are pretty helpful. If there's a lot of research on sensory processing disorders and other things like that, I think some of that information can be really helpful, those tools and strategies as well. It's an area that I work with people a lot, as well as with barometer. So sometimes people will tell me that, you know, before they start to have more increased symptoms, that things smell really strong to them. So that gives them an indication that something might be coming down the road if they know that that is something that they can identify for themselves. So at that point, we can do some planning like the RAP and other things with putting strategies in place to try and see if we can get things back on track for the person. So there's little flags that go up and nuances of function that we work on with folks around that.
I just want to add also that once the slides are distributed, we do have at the end references, and included in the references is the ESA handbook for occupational therapy for early psychosis, so that might be of use. And then there should also be references in those last slides for psychoeducation materials in both Spanish and English. And again, I would point you to the ESA website. They're wonderful. That's EASA community.org, I believe. And as well as John said, SAMHSA and On Track New York and some of the other coordinated specialty care model programs.
And if you're looking about education in terms of diagnosis and medication, I would go to the NIH, National Institute of Health webpage. That's where you would get the most up-to-date information.
Okay. Amazing. Thank you very much, everyone. Thank you for such an informative presentation and for answering all the questions. Thank you, and I hope you have a beautiful day. Thank you to all our participants.
Thank you, everyone.
Bye.
Bye.